In this video, we're going to go through the migraine headache, and we're going to cover what you need to know for your adult health Medsurg course, and of course, the NCLEX. Let's start with the pathophysiology. Migraine headaches is a specific type of headache. This is distinguished from your typical headache, from tension headaches, from other types of headache. Migraine headache is one specific type of headache. It is the pathophysiology is not 100% fully understood. We know that there's some component of vasodilation in there. So in the brain, the arteries vasodilate, they get bigger. We think that that has something to do with the fact that, or the vasodilation then causes some compression on the brain by the blood vessels taking up extra space that leaves less space for the brain. So some sort of vasodilation component to it. We also know there's an increase in a neuropeptide called CGRP, which we'll talk about in a few minutes with the treatment, but we don't 100% fully understand the pathophysiology. If your textbook does go into it, those are the two things that we'll most likely talk about, the vasodilation and the increase in the neuropeptides, such as CGRP. Let's jump to the signs and symptoms. The signs and symptoms is a headache. Everyone's familiar with that, but this one has specific attributes to it. The headache, first of all, lasts much longer than a typical headache. These headaches can last anywhere from 3 to 4 hours up to 72 hours or 3 days. That is what the official definition of a migraine is, which is much, much longer than your typical headache. A migraine headache also can be associated with an aura. That's a feeling that the patient has that the headache's coming on. Usually they get that sometime immediately preceding the headache. They may have light and sensitivity, or light sensitivity or sound sensitivity. FYI, that's called photophobia or phonophobia. They may also have nausea with their headache. And typically, a migraine is unilateral pain. That's a big classic NCLEX question. I want to sign up a migraine, unilateral pain, that it's not my whole head hurts, it's one specific part of my head, one side. So that's your signs and symptoms. Let's look at the diagnostics. There is no official diagnosis, no tool that we use to diagnose a headache or a migraine specifically. It's diagnosed based on the patient's presentation. However, we may use a CT scan, a CAT scan of the head, to rule out that the patient's having a stroke or a brain tumor or something else going on that's causing this migraine. And we'll talk more about that in a few minutes. The risk factors or the causes of a patient having a migraine, first of all, genetics is a big part of it. Patients that have a family history of it are much more likely to have migraine headaches. Stress is one of the top causes of a patient developing a migraine headache. Hormones is a big cause of it, a patient's diet, and then sensory, such as light, such as smell, even the weather, certain noises, all of those can be triggers for the patient developing a migraine. The nursing assessment for this patient should be a thorough medical history to determine their history of headaches, their history of migraines, their general medical history, any neurological issues, any medications they take, all of that. You also want to get details about this headache. When did it start? What does it feel like? Where is the pain exactly? Does it go anywhere else? What makes it better or worse? Have you had this headache in the past? All of that. You also want to ask them about a prodrome. Prodrome is one of the parts of the presentation of a patient that has chronic migraines, and that's where they have this symptomology that actually starts hours or days in advance before the migraine. So you want to ask them about that. You want to ask about aura. We already said that's right before the migraine starts, where they feel it coming on, and you want to ask them about the headache itself. Looking over to the other side, we have our nursing priorities. Number one is going to be to rule out something more serious, something like a stroke. So we want to possibly get a head CT, and we're going to be especially concerned about that if the patient has a history of migraines, but they say this is different than all other migraines, or if a patient says this is the worst headache I've ever had in my life, or if the patient's having really bad, or if the patient's having neurological deficits, or just anything that's really out of the ordinary for them in their typical migraine, we want to rule out other causes. We also want to treat this patient by reducing any stimulation around them. So we want to turn down the lights, turn down the noise as much as possible. We also want to make sure that the patient's not getting too much medication. That'll make more sense in a second. So let's talk about treatment. The first line treatment for this, and I didn't even include it on here, but the first line treatment is really your over the counter, your Tylenol or your NSAIDs. We would really much rather a patient take those over the counter options as the treatment for migraines, as opposed to having to go to the prescription medications. If we are going to the prescription medications, our first line drug class is going to be the triptans. You may also see these called the drug class of serotonin 5-HT medications. And this is going to be your sumatriptan, which is Imitrex, and a bunch of others. There are a few things you do have to know about it. And since this is the primary first-line drug class for this condition, this is definitely fair game for your adult health exam and obviously the NCLEX. So first of all, triptans are going to be your first-line drug. Triptans are going to be contraindicated if the patient has cardiac issues. So if they have specifically uncontrolled hypertension, history of uh, uh, coronary artery disease, or any chronic heart failure, any major cardiac disease, this is going to be contraindicated. But the big one is going to be the uncontrolled hypertension. Also, if this is a serotonin medication, so if the patient takes other serotonin medications, which is going to be all of your most of your antidepressants, like your sertraline, which is Zoloft, or your Prozac, all of those medications, if the patient's taking those, it's not contraindicated, but the NCLEX or your test can easily ask you what would be a concern, and the answer there would be serotonin syndrome, because now the patient's taking multiple serotonin medications, which can cause that serotonin syndrome. I'm going to talk about just for a second here about pregnancy. Sumatriptan is considered by many textbooks to be contraindicated in pregnancy, that it's teratogenic. However, in the guidelines, they're more clear that sumatriptan should not be used in pregnancy, but other triptans might be safe to be used in pregnancy. I'm not going to get in the middle of this debate, but I want you to be very clear. The NCLEX would probably say that the triptans are not recommended in pregnancy, but plenty of the guidelines say that it's sumatriptan that shouldn't be used in pregnancy, and some of the other ones, while not great, are acceptable or safe to be used in pregnancy, at least on some level. Again, I'm not getting in the middle of the debate. When a patient is taking a triptan, it is perfectly safe to also treat them with ibuprofen in addition to the triptan. And additionally, they may need some nausea medication like ondansetron or metoclopramide to help with their nausea if they're having that associated with their migraine. So again, triptans are safe to be taken with NSAIDs and with antiemetics. Next, about triptans, and the last thing I'm going to say about triptans is that patients cannot take more than 9 doses per month. If the patient is needing more than 9 doses per month, we need to switch to a preventative strategy instead of a reactive strategy. So instead of them getting a migraine, taking the triptan, we need to just get them on a daily medication, because A, that's a quality of life issue that they're having too many migraines. And in reality, even if a patient's before 9, if they're having 4 or 5 migraines a month, they're certainly valid to go ahead and ask their provider to put them on a daily preventative medication. We have a lot of different options for that. We have CGRP medications, we have beta blockers, we have certain of the anti-epileptic medications, like valproic acid can be used. We have certain calcium channel blockers that can be used for this. We have certain tricyclic antidepressants like amitriptyline that can be used for this. And we have something called ergoalkaloids, not as common, but also can be used for the treatment, the chronic treatment of migraines. Again, that whole list I just gave you, those are not for acute migraines. Those are for the treatment of chronic migraines. 2 exceptions to that. 2 of the ones I just told you, the CGRP and the ergoalkaloids, those do have a place in acute treatment. Again, triptans are for sure first line if the over-the-counters didn't work, but CGRPs and ergos can be used for both acute or chronic. There is a variation between how it's used for acute and chronic, which is beyond the scope of this video. Lastly, let's look at the bottom of the screen. We have our client education. Over here, we have to avoid triggers. So patients generally know what triggers their migraines to avoid it if possible. They should take their medication, whether it's over the counter, whether it's triptan. They should take their treatment medication as soon as they feel that migraine come on. As soon as they get that aura, if applicable, they should right away go ahead and take their migraine medication. It'll work better if it's taken early on in the migraine. And finally, consider non-pharmacological interventions, turning on the lights, maybe heat packs, cool packs, turning down the noise, things like that. The complications, first of all, the patient can develop chronic migraines. Not really that they can develop it, but patients that get migraines may end up with just, that's their situation. They have chronic migraines. It's not really a complication. I just wanted to mention that. There's no clear definition of what's called chronic migraines. Generally, if patients get them every month, multiple times, we would definitely consider that to be chronic migraines. And then finally, rebound headaches. Rebound headaches is a complication of a patient taking that triptan more than 9 times per month, or just in general, if they're excessively taking their anti-migraine medication. And we can also see this if the patient takes a daily medication and then suddenly stops taking it. All of those would put a patient at risk for rebound headaches. That's your overview on migraine headaches for your Medsurg class. Hopefully this helps you with class. You do great, and we see you in the next video.